This is Dr. Barry Bartee, and today we will be discussing a modification of the Cytoplast socket grafting technique, adding a dual layer component, which is a collagen membrane under the PTFE membrane, and we will be showing this with immediate implant placements. And so this is a 74-year-old patient who presents with a fractured central incisor that is unrestorable. We begin the procedure by making an intrasulcular incision with a 15C blade, and the intent here is to leave the papilla intact if we can do so, and then we use a microperiosteal elevator to create space in the periodontal ligament space and gently luxate the tooth and mobilize the root. You can also use sectioning here or an atraumatic root elevator type of instrument. And you'll notice we're keeping the elevation forces on the palatal aspect to protect the thin buccal plate of bone. So once the root is luxated, we remove the root and then curette the socket with a sharp curette to remove all soft tissue tags and any granulation tissue that might be in the socket. It's critical to explore the apex carefully for any residual soft tissue, and as in this case, there was a small amount of tissue. We decide here to go ahead and elevate this flap and create space for the membrane placement. I'm using a modified Woodson elevator. It's a very small, thin periosteal elevator, and just making sure that we're in the subperiosteal plane here, and you can appreciate the thickness of the buccal plate in this case, which is less than 0.5 millimeter thick in the mid portion. Now we're elevating on the palatal aspect with a small round curette. And my goal here is to create about a 5 millimeter deep subperiosteal pocket. The implant osteotomy is prepared with standard techniques, and you'll see that we're preparing the osteotomy in the palatal aspect of the socket, and we want the implant as much as possible to be engaging the palatal wall of bone. Now it's critical to graft the gap between the implant and the socket wall in order to prevent collapse and in order to preserve volume of hard and soft tissue. The implant is going in at this point. We have a nice stable implant fixture, and so the decision is made to go ahead and graft the gap between the implant and the socket wall. And here we're aligning the implant for proper abutment alignment, placement of the cover screw, and now you can begin to appreciate the gap between the implant and the buccal plate. This is a combination of mineralized and demineralized allograft. I prefer to use 80% mineralized and 20% demineralized bone. And we begin by placing this into the gap and then pushing the material vertically and actually using gentle pressure, compacting the bone into that space. And then we begin to compact the bone between the implant and the proximal wall space. And then in the typical socket, there will be a gap on the palatal aspect as well, although it won't be quite as deep as on the buccal aspect. This is the bovine type 1 collagen membrane being placed into the subperiosteal pocket on the facial aspect. We hold the flap with an instrument and then tuck the membrane down under the flap, making sure that there are no wrinkles or folds in the membrane, which may trap bacteria or result in a dead space there that could lead to infection or other wound healing complications. In this case, because of the thin, translucent buccal tissue, I chose to place a second layer of collagen membrane. And this is simply excess material that we had after trimming the first membrane. So I placed a layer of that. And now this is the PTFE membrane, or the Cytoplast TXT200. And you notice the surface structure of this material. It is not perforated, even though it looks like a mesh. It's actually a dense polytetrafluoroethylene membrane. And it is again tucked into the subperiosteal pocket on each side of the socket. I've also trimmed this to remain approximately 1 millimeter away from the adjacent tooth roots, and this is critical to allow adhesion and a reestablishment of blood supply to the interproximal papilla area. And so you see in this view, we're trimming the membrane, trying to create a little more space for blood supply. We do like to have the membrane setting on bone, so it's important not to trim too far toward the midline of the socket, but just to give you adequate clearance. Now the membrane is secured by placing suture through the flap in the typical fashion of an interrupted suture. It's important to avoid puncturing the membrane or creating a opening which might lead to bacterial migration underneath the membrane. So our goal here is to reposition the papilla and create a watertight closure between the soft tissue and the Teflon membrane. And once again, it's high-density PTFE designed to remain soft during healing, but also have the tissue response of a typical monofilament suture. Again, you can see the protection of the underlying membrane while the suturing is being done. The flap is picked up and protected from the suture needle. And now we're placing a crisscross suture across the central part of the socket to improve the flap adaptation against the membrane and also to eliminate any dead space that may occur. In tightening the sutures, it's important to avoid over-tightening or creating any blanching of the soft tissue. You want to make sure that the soft tissue margins are nice and pink. And so the goal is to achieve a good snug closure but not over-tighten the suture knots. The Cytoplast suture works best with a double throw initially, so I typically will make a double throw to the right and then a lock back to the left, and then another single throw to the right. We're applying pressure with dry gauze onto the wound for approximately 3 minutes, again to achieve good hemostasis and eliminate dead space. And then trying the provisional restoration, it's critical that it not impinge or cause blanching on the interproximal tissue or on the facial tissue. Checking the occlusion to eliminate any potential premature contacts. And this is the clinical view of the patient at 2 weeks, showing good soft tissue response to the membrane. And this is the clinical view at 3 weeks. And at this point, we will remove the membrane by applying topical anesthesia. You can see the maneuver required to remove the membrane. It's very simple, very easy to do. And then this is 2 weeks following removal of the membrane, and you can see the socket has re-epithelialized and is healing well. And from the occlusal view, you can see good maintenance of bone contour and soft tissue contour as well. So in conclusion, the Cytoplast technique allows for predictable socket reconstruction without the disadvantages of primary closure. It allows for the enhancement of soft tissue both in thickness and in width, and allows for site development procedures, or can be readily adapted for immediate implant placement as well. We would be happy to answer any questions you may have about the Cytoplast technique at the following email address, or you may feel free to call our toll-free number at any time.